So once again, welcome to our joint webinar with Yetenaweg and Ethiopian Society of Internal Medicine. We're glad you can be here with us today. So before we proceed with the webinar, I would like to say a few introductory remarks about Yetenaweg. So Yetenaweg is registered in Pennsylvania, USA as a non-profit organization that is entirely run by volunteer members. So it initially started with 2 co-founders and volunteers, and it has grown to include more than 70 active volunteer members spanning across 5 different countries and counting more. As you can see from the image above, these are all Yetenaweg's volunteers. So Yetenaweg mainly has 4 projects and engagements area. So the first is the health promotion. So this is usually via discussion and articles involving the health of the general public, involving health policy and its implementation as well. Another one of our project and engagement is through the community engagement. So it could include blood drive, inclusiveness or equity projects, fundraising campaigns, many more. And our third engagement is the mentorship and skill sharing. So there's going to be direct mentorship, there's going to be soft skill mentorship, career and professional development, and webinars as well. So the last is our continued professional education or through the CMEs, just like this one. So Yetenaweg is more than a digital platform. So all volunteers actively engage in several of the aforementioned engagements and platforms. These are all a picture of our volunteers engaging in different events. This is also a picture of our volunteers and also a screening program that was provided to our attendees a couple of months back. So Yetenaweg has also collaborated with ROHA to provide healthcare writing article competition, along in collaboration with IMSA as well. So the third round of health article writing competition was organized with IMSA. So ROHA Medical Campus will usually award travel grants for 2 health article writing competition winners, and Yetenaweg on its behalf will award pulse oximeters for the top 20 winners and litmus stethoscope for the top 3 winners. So the top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. So this is a picture. So on the left-hand corner is the 2021 article writing competition winner with the 2022, and this is the 2023 article writing winners. They were provided with the opportunity to travel abroad and participate in several engagements. So Yetena has also collaborated with ROHA to provide a research fellowship award. So this was done in 2 main areas, namely at Kurambasa Hospital and as well as St. Paul Hospital Millennium Medical College. So it initially started on 14th of March in collaboration with Addis Ababa University Medical Faculty. 3 departments, mainly oncology, radiology, and internal medicine, were chosen, and research grants were awarded for the top 4 winners and mentorship for the next 10 winners. And the other half was with St. Paul's Hospital Medical College. It was provided for medical students, mainly internists. So research grant is going to be awarded for 2 winners. It has already been launched, and the winners will be announced within the coming few weeks. So these are the winners from Black Lion, from internal medicine, oncology, radiology, and another one from internal medicine as well. So coming to our CME, as you know, our CME is freely accessible. Yetenaweg partners with several medical associations, including Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine, such as this one, to provide continued training for healthcare professionals. So we've had more than 30 CME webinars so far, and we've started again for the year 2024. So our average webinar attendees vary from 150 to 200 healthcare professionals. So as I've mentioned, for the year 2024, we're focusing on emergency and surgical medical cases, ENT, pediatrics, OBGYN, and various others. Closely follow our social media outlets in order to get notified about our upcoming webinars. So we invite remote, local, and international speakers. So you can access our previous CME sessions on our YouTube channel. So you can also get updates about our upcoming CMEs by joining our Yetenaweg for professional Telegram channel. We'll provide you with the links shortly, or you can follow our social media posts via Twitter, Facebook, LinkedIn, Instagram, whichever you find more convenient, will do. So to get the best experience out of the webinar, send your questions directly to the Q&A or to the chat box. And at the end of the webinar, your questions will be directly addressed to the guest speaker. And to get 2 CU points, you must attend the whole session virtually. So the minutes will be checked by Zoom attendee reports. You have to fill in the Google form for personal details in attendance, which is along with the quiz link. And you have to be able to score 50% or more. And if you've managed to do all of the above, you will get your results right away. But the certificate will usually take 1 to 2 weeks to be delivered to your email inboxes. So we ask that you wait patiently. So with that said, this will be all about Yetenaweg. So with us today, we have Dr. Abel from Ethiopian Society of Internal Medicine. He is the current CPD director and coordinator on behalf of ECIM. So if you can say a few remarks about ECIM, Dr. Abel.
Okay, thank you, Tadael. Good evening, everyone, and welcome to our today's CMB session. To say a few points about Ethiopian Society of Internal Medicine. Ethiopian Society of Internal Medicine, or ECIM, is one of the professional associations established more than 10 years ago, currently having more than 1,000 members and around 1,500 associate members. We were established with a mission of improving the quality of healthcare by fostering clinical excellence and medical professionalism in the field of internal medicine. And we want to be recognized as a leader in promoting quality clinical care, advocacy, education, and research in internal medicine and its subspecialties in Ethiopia and beyond. As part of our routine activities to ensure this mission and vision, we have a routine CPD activities which usually focus on clinical topics. But as some of you may know, ethics and professionalism trainings are one of the mandatory requirements for licensure of healthcare professionals. So we wanted to provide an opportunity for our members and also to the healthcare community at large. So today, in collaboration with Yetenaweg, we have prepared a webinar session on medical ethics entitled Ubuntu for Clinical Practice, Values Beyond Colonial Ethics, with Dr. KIRUBEL MANYAZEWAL, who is an expert in this field, who he'll tell you about his bio later. And we are so grateful to Dr. KIRUBEL for volunteering to give this session, and also to Yetenaweg team for preparing and giving us this platform and facilitating. I hope all of you will enjoy and benefit a lot from this presentation. And thank you. Back to you, Tadael.
So thank you very much, Dr. Abel. So as Dr. Abel has told you, our webinar today is specifically on medical ethics, titled Ubuntu for Clinical Practice, Values Beyond the Colonial Ethics. So our guest speaker today is Dr. KIRUBEL MANYAZEWAL. So to say a few things about Dr. KIRUBEL, Dr. KIRUBEL MANYAZEWAL Muse is a bioethicist with an interdisciplinary background, combining PhD in biomedical ethics from the University of Basel, Masters in International Community Health from University of Oslo, and BA in social work from Addis Ababa University. So Dr. KIRUBEL has received grants from European Union and the University of Basel for his doctoral project, and he has also won the JETS d'Or of Geneva Award for International Science Talk Competition at the Geneva Health Forum held in 2022. He is currently serving as an editor of the African Journal of Bioethics, and is also a reviewer for various international and peer-reviewed journals. So his experience outside of academia include health policy consultation, ethics consultation, fundraising, gender mainstreaming. So Dr. KIRUBEL's broad research interests include healthcare analysis, bioethics, aging, migrant health, decision-making in healthcare, and research methods. So with that said, Dr. KIRUBEL, the floor is yours. Please proceed.
Thank you so much. I really appreciate it. Thank you so much for the lovely introduction. So then I proceed first by sharing my screen. Okay. Let me know if you if you don't see my screen or my PowerPoint. I hope it's quite visible. So yes, we are going to talk about Ubuntu Ubuntu philosophy and its relevance for clinical practice, and a little bit about some of the Ubuntu values that are, I would like to call, beyond the colonial ethics. And I mean, I know, first of all, I want to acknowledge that this is a very broad concept and very broad topic. But at least it's very nice if we have a brief or an introductory understanding on this topic, and then I hope it will encourage us to go deeper, to read more by ourselves. So to just give you an outline of the presentation, I will start with clarifying or explaining what Ubuntu philosophy is. And then I will also, talk about the principles of Ubuntu and how or where it comes from and so on. And then I will proceed to colonial ethics. And by that, I will also, talk a little bit about colonialism and ethics as a concept, and why. I mean, this is also my personal opinion from my bit of reading and analyzing ethics. So why I think there are some aspects of ethics that I prefer to call or to refer to as colonial, so to speak. And then the third part is, of course, I will say a little bit about how we can implement Ubuntu in clinical settings or in clinical practice in our context, of course. And then finally, I will talk a bit, on what are the challenges of implementing Ubuntu philosophy. So let's start with Ubuntu philosophy, what it is actually. I mean, you might have heard of this concept or this philosophy before. If that is the case, then that's very nice. And then for some of you who might have not heard of this, then I would like to say a few things. So the term Ubuntu, as you might have guessed, is not an English term. It comes from the Zulu and Xhosa languages in South Africa, and it can be translated as humanity or humanness as well. But then the central element of this philosophy is the idea that I am because we are. So that's sort of also the translation to English. So I am because we are. So that means I exist because you exist. I live because you live, or we live. So it focuses on community. So that means I am the result of my community. I breathe because you breathe. And that is a very interesting and quite deep concept. And if you look at Ubuntu in some African countries, they have their own aphorisms or sayings and ways of, understanding. And then some of them say Umuntu, Ngumuntu, Ngabantu, and that meaning a person is a person because of or through others. So the underlying or the basic concept that we can, or the basic idea that we can take from all these definitions or understandings is that Ubuntu philosophy focuses on interconnectedness and interdependence. These are very important elements in Ubuntu. But then let's have a look at the principles of Ubuntu. I mean, as any ethical value that comes also from the Western world, this Ubuntu philosophy has also principles. There are mainly 4 principles, and they are solidarity, coexistence, compassion, and respect and dignity. Of course, I'm sure these terms are quite familiar to all of us, or most of us at least. But then in the context of Ubuntu philosophy, what are they? Let's have a look, briefly have a look at that. Can someone tell me if this thing here is sort of covering the screen? It's not, right? So the screen is fully visible. It's only in my case. Let me.
It's fully visible, Doctor.
Fully, yeah, that's great. So I just put it here. It's disturbing me. Now it's sorted out. So the first principle is solidarity. So I mean, I don't know. At least in my case, I hear this term a lot. People say, okay, we stand in solidarity, and in demonstrations or in campaigns and this and that, people like to use this term. So solidarity can be understood as a combined effort of individuals for the survival of their community. And it stresses on the willingness or the commitment by members or community members to leave their individuality behind, or the sense of individuality. I am because I am kind of motive or kind of idea, and then to work for mutual flowering of the entire group or for community. That is what solidarity is. It's about unity, unconditional love and respect for each other, and so on. And there's one interesting African saying, at least scholars put that put this as an African saying, that goes like, one finger cannot crush a grain of wheat on its own. So you need the help from the other fingers. I mean, I don't know, you have to be a very much talented person, unique person, to crush a grain using your own, like your one finger, and then you put the grain here and then you crush it. I mean, might happen, I don't know. But then I can say under normal conditions, you have to use all the fingers to crush a grain of wheat. So that is the idea of solidarity. When we look at the second principle, which is coexistence, I hope this is also a familiar term. As the term indicates, it's about existing together. So mutual interdependence among members of a community. So it's not about dependency, it's not about independence, it's rather about interdependence, and that's very important. So that means I cannot exist in isolation. So for me to exist and function, I need to depend, but then I should not be completely dependent. So it's kind of an interesting balance between the two sort of extremes, I can say. And it's also based on the acknowledgement of diversity. We're diverse, you have unique knowledge and expertise and cultural background and so on. So I can depend on you, and then I have some unique, you know, we are diverse, and then but still we can depend on each other. That is a very interesting thing. The third principle is compassion. This is also a familiar term. Sometimes, I don't know, we might have said to each other, please show compassion, be compassionate, I am compassionate, this person is compassionate, and so on. So as the term already indicates, compassion means humans' ability to understand others' challenges, sufferings, dilemmas, and experiences. And it's about care, showing sympathy and concern for others, and the desire to share what you have and say, okay, I have something, and then you may not have that thing, so I want to share that with you. That is compassion. And the last principle is respect and dignity. And by the way, these two concepts are usually, they usually get confused by many. So dignity is a bit, or I can say even a much higher version of respect. So it is something that is, it can be something that is very natural, innate, and then you respect a human being because that person is a human being, not because he has done something, not because he has not done something. You just show respect because that person is a human being at the end. So the fourth principle of Ubuntu philosophy is that. So we should respect and we should acknowledge the dignity of each other, and show unconditional respect. And then we also take respect in return when we respect others. I mean, in some context, of course, you respect others does not mean that you will not be disrespected. Unfortunately, that happens, but then at least in principle, it's very important that we show respect, regardless of who that person is or that person's background. Yes, now we go to the second part. So now we have a brief understanding of what Ubuntu philosophy is. I mean, it's a very broad and deep concept or philosophy, so I really encourage you to go and read by yourselves. But then, so what is colonial ethics? And then by that, I would like us to start, when we get to that, I would like us to start with a brief understanding of what colonialism is. But then, even before we go to that part, I want to pose a question. And this question for you is, has Ethiopia ever been colonized? Or is it a colonized country? And then, I mean, this is a very simple question, right? So if you Google, and Google says, or there are many sources that say Ethiopia is the only country, that African country that has never been colonized. Some sources say it is one of the two countries, together with Liberia. So we know that it's not colonized. I'm an Ethiopian myself, of course, and I'm very happy about this, very proud. But then I also want to invite you to critically reflect on this. And then for, I mean, as an ethicist or Ubuntuist, or, you know, as even a medical practitioner, it's very important that we critically reflect on things or on ideas that we collectively tend to agree on, right? So it's nice to kind of have a critical look. So before that, before we answer this question, I would like us to look at two concepts that usually get confused, or that maybe people do not know about, the difference, especially. I mean, colonialism, we have heard a lot about colonialism. We hear a lot about colonialism and neocolonialism. Some of us might know, and then some of us might not know, and then we may not know the difference, but only the terms. So when we talk about colonialism, it's very straightforward. It's about you know, the direct political and territorial control of Western powers using military conquest or exploitation of resources. And this was mainly by European powers or countries from mid-15th century to mid-20th century. So, I mean, some of us know history, right? And then we know what happened. We know the killings and so, and the resource, the robbery, so many things. And some examples could also be colonial settlers going to, you know, moving to a place which they, you know, referred as empty lands, but then, for example, in the case of the USA, we know that there were people already there, but then what they did was they just killed the people, the indigenous people, and then they said, hey, we found a new land, which is not the case. But also a British Empire, what the British Empire did, you know, it had so many colonies and then so many killings and robbery and so on, and also missionaries, Christian missionaries, in the name of, you know, Christianity and so on. They have done horrible things in the past. And then now when we talk about neocolonialism, that is a more indirect means, such as using economic pressure or cultural influence. And it was a rather, or it is rather, a subtle dominance, using, you know, financial aid collaborations or multinational corporations and so on. And then this neocolonialism started after the formal end of colonialism, which is mid-20th century, and it is still present today. So, I mean, we can mention different examples like economic agreements and cultural influence through the media and multinational corporations and agreements that, you know, sort of show Western influence or Western power and colonial ideologies and so on. So that is neocolonialism. So the kind of the hidden, the soft or the cold or whatever adjectives you want to give it. So all those kinds of movements are or could be categorized under neocolonialism. So when we go back to the question, has Ethiopia ever been colonized, or are we affected by colonialism? I don't want to answer that question. I leave that to you. But then I want to go further, and then I want to elaborate on the effect or the impact of neocolonialism on Ethiopia. Now we know about neocolonialism, so it should be quite easy to sort of understand what that is. Or the influence or the impact of neocolonialism on Ethiopia. I mean, in different ways, we know that, right? For example, neocolonialism has caused economic dependency on Ethiopia. There are economic trade relationships, economic relationships that are unfair or unequal, debt burdens or limited economic autonomy. I'm not an economist. I remember taking economics as a subject in high school, one of the subjects. But then I kind of have a bit of understanding about how especially economic unions or trades work between two countries. So I mean, we know that we have made somehow dependent on some countries and so on, and that is a very strategic, using your weak points and then kind of imposing your colonial, I don't know, ideologies or norms and so on. Yeah, that is one part. The other one is cultural subjugation or control, and this is a very, 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 I would say, very serious problem that we have been experiencing, the cultural change. And if this cultural change is for good, that's fine. And by the way, when I say all these things, I'm not being completely against with the idea of taking nice or helpful norms or cultures from abroad. It's very nice. We can learn things from others. I completely acknowledge that. So please do not, yes. So I'm not saying that, but then it's very important that we do not use other cultures or other norms or values to blindly hate your own identity. That is the problem. So, I mean, indigenous practices are being replaced by Western norms, blindly replaced, simply because we just want to be like them, for example, or and so on. And imposition of foreign languages. I mean, it's really, how do I put that? Unpleasant for me to see there are so many schools or kindergartens which are not international. If they're international, then that might be fine. But then private schools who punish their students if they speak Amharic or a local language, Afan Oromo or any other. And this is really not nice. And this is what we are seeing. So imposition of foreign languages, or even dress codes, how you should get dressed. I mean, for example, what is your imagination of a professor at a university? How should that professor get dressed? I mean, we could imagine it should be like, with a suit and then with the tie and whatever it is. And then that is a professor, or that is like a respected person with that kind of dress code. But then if that person wears, I don't know, cultural clothes from RC or from Gonda, or I don't know, and then how do we react? Do we have equal respect or what? I leave that to you. So introduction of dress codes and hairstyles and so on. There was a time, I have also personal experience. There was a time I had a bit of like an afro hair. I did that on purpose because I wanted to a bit of personal sort of research. And then there were people who were, of course, I understand where they come from, but then there were people who were saying, okay, with this hair, with this afro hair, I'm not sure if you can get a job at Addis Ababa University or Jimma University or, you know, any university, an Ethiopian university. And I was like, okay, so I cannot get a job in, you know, at a university, at an Ethiopian university because I look like an Ethiopian, because I have, you know, a curly RC looking hair or Afar looking hair. So that is really, really, really problematic. And this is what cultural subjugation, or this is what I mean by the negative consequences or effects of neocolonialism on Ethiopia. And then maybe a couple of more things is political interference. You know, igniting or supporting political unrest. We have experienced that. I'm not good at politics. I apologize for that. I'm more interested in African politics than Ethiopian politics. But then, you know, in Ethiopia, I also see that, you know, or understand that there were so many Western, you know, or colonial powers being involved, so that we can go, you know, so that we go through all these wars and conflicts and so on. We know that, right? And that is really painful. And actually, there is one thing that I say to my friends and colleagues when it comes to this, and then I tell them, I'm not good at politics. But then my understanding is that if you're an African country, and then if your government or if your leader or prime minister or, I don't know, president is hated by colonial powers, that is a sign that that government is yours and you have to vote for that government. Regardless of, you know, I mean, of course you have to see the secondary, okay, and then the third level, okay, you have to look at different things. But then the first important thing, if you're an African country, is make sure that your government is hated by colonial powers. If it is hated by colonial powers, you are safe. If it is loved or favored by colonial powers, you are done. Even though you get some candies and, you know, tentative pleasures or good lifestyle or standard, but your future is done. So I'm sorry, that's my quite strong opinion on this matter. So this is how neocolonialism has impacted Ethiopian culture and Ethiopianness. And lastly, of course, scientific or technological constraints, for example, lack of digital freedom or restrictions, because, you know, you support this, you do not support this, you do this and that. So you will not have, you know, access to advanced technologies and this and that. Yes, so I mean, I just wanted us to have a little bit of break on this beautiful island. That's why I brought this picture. So I leave that to you, answering the question, the earlier question. So I want us to first ask, okay, which colonialism are we talking about? Are we talking about colonialism, the physical presence of colonial powers in the past, or are we talking about neo-colonialism, right? That's very important, because unless we know, I mean, I'm not a clinician, so my background is not medical or medicine. But then I strongly believe that for you to get cured or treated, your disease must be known. So if you don't know your disease, it's very difficult to, you know, get you to give you the proper treatment. So that's why if we say, okay, blindly say, we're fine, we have no problems, we are, you know, protecting our culture, this and that, well, it's very difficult to address that problem. Let's go to this part further. So when we want, you know, now we have we already had a look at colonialism and neocolonialism. So what are the implications in ethics? What is ethics? And how is colonialism reflected in our daily clinical practice in the context of Ethiopia? So we have already established that colonialism has impacted local moral underpinnings, local indigenous cultures, values, and then it might have made us probably, I don't know, hate some of our values, and then we get divided, and then we fight, and then we lose our beautiful values, and so on. And so that is the historical and ongoing influence of colonialism on ethical frameworks and even decision making. How do we reach decisions in clinical contexts? I'm sure you have experienced it. I mean, as I said, I'm not a clinician, right? So, but then I have experience interviewing, researching, or talking to clinicians, specialists, and so on. So I'm sure that you might have, experienced so many clinical dilemmas or ethical dilemmas. What should I do? How should we reach this decision? Because on one hand, you are trained in the Western within the Western biomedicine or philosophies, and our curricula, all those things, the things we read, the theories we refer to, they are more influenced by that side of the world. But then when you go to practice, or to clinical practices, things are different. And so by colonial ethics, I mean that overlooking or dismissing indigenous knowledge and cultural practices. And sometimes I even say to some of my colleagues that the term ethics is alien. Even the term ethics is, I feel that sometimes it is alien to us, Ethiopians at least. And then, of course, some of African countries as well. But then I might need to do a bit more research on that to reach that conclusion. Because let me give you an example. How do you define, or how do you translate, how do you translate ethics to Amharic? For example, it is Sinamugbar, right? That is the Amharic translation, at least to my knowledge. You can correct me if there is a recent, new, more interesting Amharic term for ethics. I'll be very happy to know. Please let me know. But then otherwise, what I know is ethics is translated as Sinamugbar, and Sinamugbar is not ethics. That's the problem. When you translate Sinamugbar to English, then it is not ethics. It's more like behavior or the study of behavior. I agree. Ethics, the word ethics it comes from the Greek word this and that, and ethos, which means the study of behavior, and this and that. But then the contemporary understanding, or I could also say notion of ethics, is not that. It's much broader. And by the way, one of the most difficult things for me is to define ethics. If someone asks me, okay, what is ethics or what is bioethics? And I'm like, okay, I'm not happy about this question, but then I'll try. So it's a very broad, very complicated concept. Simply, we might say, okay, what's right and what's wrong. It's about, understanding what's right and what's wrong, or I don't know. You can already see that I don't know. So it's a very much complicated concept. So, but in Amharic, what we get is Sinamugbar. And then if you come to me as an Amharic speaker, you come to me and then you mention the term Sinamugbar to me, what I could think of is, okay, the behavior of someone. Because I confirmed this when I did some interviews for my doctoral work, because I was interviewing health professionals and older patients. And when I was, I developed my question. It was a qualitative interview, so I developed my interview questions or interview guide, and then that was done in English. So let's say one of the questions, if I sort of recall, was a general question as an icebreaker. So I had this general question that goes like, what is your experience in this hospital, Hospital A, and what are the ethical issues that you have noticed or that you have seen? And then I had to translate that to Amharic, because I did the interviews in Amharic, of course. So when I translated, and then I asked them in Amharic, yeah, ያስተዋላችኋቸው የስነ ምግባር ችግሮች ምንድን ናቸው? Right, so in Amharic, that is how I translated me. በዚህ ሆስፒታል ውስጥ የነበሩት ልምድ ምንድን ነበረ ወይ የነበሩት ምንድን ነበረ? and then ያስተዋላችኋቸው የስነ ምግባር ጉዳዮች ጉድለቶች ወይንም ችግሮች ምንድን ነበሩ? That was how I translated it. And then people started to talk about, especially, I mean, not health professionals, but then the older patients started to talk about the behaviors or the conduct of health professionals. And that was not the case. I mean, of course, that's part of the ethics thing, but then ethics is much broader than that. So they started saying, okay, health professionals are like this, some of them are nice, some of them are this. They started complaining, and the focus was only on health professionals' behavior. But then ethics is much broader than that. So that is what made me think, okay, ethics is really, why are we suffering? Why am I suffering to explain what ethics is? You know, because I wanted to know more. So I had to use different concepts. I had to say, okay, fairness. Was it fair? Was it right? Or was it, I don't know. You know, I started using different concepts to simplify, to segregate, if that's the right term, or divide the big, complex, complicated concept of ethics. And then I realized, why are we suffering? Because this ethics, which is an alien concept, is introduced. And now we are suffering. So not suffering, but then, yes. So it's quite challenging. And I also asked colleagues, I mean, who speak Afan Oromo. I don't speak Afan Oromo, so I have colleagues who speak Afan Oromo and philosophers or who study philosophy. And then I even asked them, okay, how do you translate ethics to Afan Oromo? And then also asked people who speak Tigrinya, and then I asked them, how do you translate ethics to Tigrinya? What is the sort of equivalent translation of ethics? And the reason why I'm saying all these things is that this is a very unique, difficult concept for us to digest and to live by in our daily practice. And then, I mean, you can imagine in other countries, even bigger countries like Nigeria with many, I don't know, around 200 people and around 500 languages, distinct languages. I'm not talking about dialects. It's a very huge country. And then how are they dealing with the concept of ethics? So I'm not saying that we should hate, please. I'm not saying that we should hate or avoid ethics. It is very nice. It has very interesting, of course, I mean, there is no question in that. But then I am sort of encouraging you to be critical towards these things, these philosophies or values that we just blindly take and try to replace our indigenous values with. And that's very important. So when it comes to, of course, principles of medical ethics as well, there is one professor that I really admire. I really like his works, his writings. He is Professor Kevin Behrens. He works at a university in South Africa. And then I really like what he suggested. Because the principles of medical ethics, as we know them, there are four. You might have heard, most of you, we say autonomy, beneficence, non-maleficence, and justice. These are the four principles. And then this person, this professor, suggested that we replace autonomy and justice with respect for persons and harmony, which I found quite interesting. And he's suggesting that in the context, in the African clinical context, which I really like, and I completely agree, because this, I mean, autonomy and justice, recently there is this new concept of relational autonomy. So that means, I mean, autonomy is, as we know it, the patient must decide, individual decision of the patient. And the traditional understanding of autonomy, which is also criticized, highly criticized by Western writers or writers from that side of the world, they're also criticizing that, and I agree, which is a nice thing. But then recently, what is developed is relational autonomy. So, okay, don't say the patient must decide. Let's talk to the patient, and the final decision is the patient's. Don't say that. Let's focus on relationships of the patient with the family, with the health professional. Let's hear the health professional's opinion as well. Let's consider, because the health professional is also, you know, a human being with an experience, with this and that, with disease experiences, with, you know, like the patient. So it's not like these are two different creatures. So the health professional's opinions, the family opinions, the community opinions, and so on. So let's consider that as well. So do not be rigid and say, okay, the patient's the patient, end of story. But then, you know, let's focus on that. So that's why this professor suggested respect for persons, because when you respect the person, that means you respect the community as well. When you respect a personhood, an individual, you sort of respect that community as well, because the person is the product of the community. That is how we should treat. And then we should focus on harmony instead of saying, okay, justice, let's be just. No, let's harmonize, let's come together. And then let's decide based on harmony. And that is quite interesting. So this is how sort of colonial ethics kind of being criticized. But then recently, of course, I mean, due to globalization, cultural exchange, and this and that, there are so many values that sort of migrated to other countries, to high income or Western countries, and of course, many values also migrated to our context. So it's really nice. I really wish to see a very interesting balance between these two sort of extremes traditionally, but there is that balance. That balance is growing, and that's really nice. So it's really nice that we are sharing our values between countries and contexts. So the third part, okay, now we said quite a bit about Ubuntu philosophy and ethics as we know it, especially traditionally. So now, how should we implement Ubuntu in clinical settings? I mean, this should be an easy thing. Once we know about Ubuntu philosophy, it should be easy to have a brief understanding of how we should implement it. But then when it comes to practicalities, it can be very challenging because of the broad, the complex, the very beautiful, I can say, nature of Ubuntu. It doesn't sound realistic because we have gone too far from our values. It took us so many years, so many decades to leave our values, as I said earlier, due to neocolonialism or colonialism, this and that. So now we are in a very tricky situation, and it's very difficult to return and claim our indigenous values. And sometimes it doesn't even feel realistic, right? When we talk, that is what people sort of criticize Ubuntu philosophy. They say, okay, it's not realistic. Are we really like that? I mean, of course, there is always problems, or how do I put it? Every society or every culture has its own weaknesses, if you want to say that, or, you know, nothing is perfect, of course, but then still it's a beautiful philosophy. And then we used to, at least Africa as a society, as a big society, it used to have that beautiful moment, beautiful, peaceful, until it got disturbed at some point, as we said earlier. But then, of course, there were problems as well. I'm not saying we had a perfect society. So there are 4 major areas, at least. We can focus on that. 4 major areas where we can say, okay, this is how we can implement or practice Ubuntu philosophy in clinical settings. So the first one is patient-centered care. So it helps us to bring patient-centered care. I mean, Ubuntu philosophy emphasizes the importance of treating patients as individuals. We should not disregard or overlook that as individuals, and as well as community beings. So it does not mean that the individual has no voice, has no place. It does not mean that the patient or your patient does not have a say. Of course, your patient's perspectives or voices are respected, as we said, respect for persons instead of autonomy, right? So, but then that means healthcare providers prioritize the holistic well-being of the patient and consider their social, emotional, and cultural needs. Listen to the patient in the patient's context, understand the patient instead of saying, okay, this is what I know. You know, I've studied for 6-7 years, so I know what I'm saying. Just accept what I'm trying to say and go. Of course, sometimes we say that because, you know, it's really difficult. I'm not judging you, but then it's really difficult. I mean, you have so many patients lining up, and then it's very difficult. You know, it's all about our resource issues, and then we have a lot to do, and we are human beings. So we are probably offended by something else, and we're tired, and we are not happy about the salaries we get, which is also part of the Ubuntu philosophy. Ubuntu philosophy also deals with how should we treat healthcare providers, because healthcare providers are also, it's not only about patients, right? It's also about healthcare providers, and then they should be heard, because otherwise, if you don't do that, we are unfair to healthcare providers, but also unfair to the healthcare delivery in general. So that's very important. So try to see the patient and then understand the patient's context, and then say, I am because my patient is. I am the result, the product of my patient. The patient can be uneducated. Let's say, when I say uneducated, I put it in quotation because formal education is one aspect of education, but there are many people who have not gone to schools, but who are much more knowledgeable and amazing life skills than us. So the patient can be that. The patient may not have any idea about, you know, I don't know, anything, you know, based on our glass, of course. So I am because my patient is. I am the result of my patient's community. So my patient is my what? Existence. So try to have that kind of, every time you talk to the patient, every time you talk to every time. And also, if there are, I don't know, supervisors here attending this meeting, this webinar, health administrators or medical directors, you should also say, I am because my employee is. I am because this clinician is. So do not just show I'm the boss and then do this and that. Instead of that, you are there, or you exist because that physician exists. So it's very important that we have this kind of how do I put it, understanding and care to each other, and we should treat each other as patients as well. When I say patient-centered care, I'm also trying to emphasize that, you know, the healthcare provider should also be seen as a patient for the patient, right? And then even between hierarchies, that's very important. So this is a very important point for our peaceful and productive clinical environment. The second thing or point is collaborative decision-making. It is somehow related to what I said. So Ubuntu philosophy promotes collective decision-making, shared decision-making, consensus building, right? So we should collaborate, we should involve others. I mean, I want to take you back to what I said about my research experience. And then some of the health professionals that I interviewed, they were saying, okay, sometimes it's really difficult to make decisions. So what we do is we invite, for example, I don't know, someone from the same religion as the patient. So we collaborate, we decide things together. to convince the patient. You know, there are some patients who refuse to take blood. I think we call that blood transfusion, if I'm not mistaken. Sorry. So some of them, they don't want to do that, or because of religious, and then some of them, they don't want to take tablets or to take their medicine because they're fasting. This is a very serious challenge with older patients, especially. So to convince. So when we make decisions, when we want to kind of explain things to a patient, we all involve others, but not in a way that you just expose everything about the patient to everyone else. Okay, I have this patient here. He has these conditions, and his name is this and this, and then he lives. So not that way, of course, right? So it's very important that we collaborate and we make decisions together, involve the family if needed, and so on. The community engagement, of course. Ubuntu philosophy emphasizes the importance of community and interconnectedness. So in clinical settings, this can be implemented through community engagement initiatives such as health education programs, outreach clinics, and partnerships with local organizations. So health administrators or leaders who are in this webinar, this can be something that you can use to implement Ubuntu philosophy in clinical settings. Consult, invite community people, and then allow them to say things. I mean, because our hospital, our clinic, if you have private clinics, is because the community is. It's not about profit making. I mean, unfortunately, these days, medicine and business are confused. So it's all about, it's becoming all about profit making, but it's not that. I mean, it's okay. You need profit, of course. I mean, you have to make money so that your service continues, and then we benefit. That's very important. But then, go to the community. Sometimes once in 2-3 months, it may sound silly. No, just invite community members, have some talk with community elders, culturally knowledgeable people, and then, talk to them and then get some ideas, health education programs, ask them, what is health for you? What is death for you? Because, right, it's very important that we do that. Otherwise, our understanding of death might be influenced by other cultural norms. And then death in the Ethiopian or in one cultural context might be different. So you don't know, you might be surprised. Ask people, involve their ideas. The last point on how we should implement, or we can implement Ubuntu, is, of course, cultural sensitivity. Be open to cultures. I mean, this also is somehow similar to what I said earlier. In clinical practice, healthcare providers should be aware of and respect cultural beliefs and practices of their patients and incorporate cultural sensitivity. This way, it can be amazing. It can be respectful. The care can be respectful, and so on. But then the last and fourth point is the challenges. Okay, I mean, we said a lot, very nice, beautiful ideas, heavenly, unrealistic, utopian ideas. But then, yes, there are challenges in implementing Ubuntu philosophy. I acknowledge that. And as I said, I mean, this is a broad topic, and then we might need to read more about this. One challenge could be cultural sensitivity. I mean, as healthcare professionals, we might need to get more training to understand and respect diverse cultural beliefs. So it needs more training to have trainings like this, or webinars like this, or other trainings also, reading and individual trainings and so on. That's very important. Otherwise, it's really difficult to understand, even to understand Ubuntu philosophy and its implication for clinical practice. That is one challenge. And also Western biomedical dominance is another challenge. As I briefly mentioned earlier about our curricula, the way we are trained and our theories, and even the words, medicine, when we, the topics, I don't know, anatomy or this and that, everything seems seems to be very much influenced or shaped by Western biomedical norms or understandings, and that's why we can have challenges translating. And then the problem is when we are trained in that world and we go to, I don't know, very remote area, very cultural area, and then we get confused, and then we start judging people. Ha, uneducated, or ha, illiterate people. They don't even know how to deal with this and that. You know, we just end up judging people, and that is sort of problematic. And that is also, anyway, the end aim of neocolonialism. So another is power dynamics. This is also quite challenging, because there can be, when you want to implement Ubuntu philosophy, you might notice there are, because you want to involve people, you want to, collaborate, you want to respect community values, and then you see values conflicting sometimes, you see people or hierarchies conflicting, and that can be quite challenging. And I mean, to address this, we should always try to create dialogue, talk about things, try to reflect on our values, on our, sometimes it's nice to just sit down. It might be silly, but then to sit down and then maybe write, or say to yourself, okay, what am I? Who am I? How am I trained? I do that as a qualitative researcher. I just sit down and then try to put my biases. Okay, how am I biased? Okay, I am an Ethiopian. How being an Ethiopian could bias my understanding of this and that? Okay, it might be my religious background. Okay, I am this from this religion background. Okay, how does that impact my decisions or my thinking? Okay, and from this, I speak this language, and how that can, have impact. So sit down and reflect on your identity or parts of your personality. That's very important. The fourth one is, of course, resource constraints. It can take a lot, because there is one philosopher, African philosopher, I forgot his name. There's one thing he said, I'm paraphrasing, right? So it's for Africa to develop again, it's very important that Africa returns back or reclaims its dignity. I wish I remember word by word. It is so nice. I remember how nice it is, but then I don't remember the words. So we should reclaim our dignity if we want, because if you lose your identity, if you do not have a good understanding of your identity, there can be no economic, political, social development. If you don't like yourself, if you don't like being an Ethiopian, if you don't like your cultures, your tiny, gritty, little, values, then you cannot develop. Trust me on this. I'm sorry, I'm very confident on what I'm saying, but trust me on this. All your economic developments are temporary. So for 10 years or 5 years, you might have, okay, amazing economic development, but then you will crush. I mean, there is no doubt. So it's very important that we reclaim our identity. We appreciate our identity, who we are. Of course, acknowledge if we have any bad sides or weaknesses, of course, acknowledge them, and then try to work on that. I'm not saying we should be blindly proud. But then don't blindly hate your identities or undermine your identity, and that's very important. And that's also the reason why we have all these racial conflicts or ethnic conflicts and so on, because we have not learned to appreciate each other's cultures and Ethiopianness, and then we focus on something else, and that is the foundation of all of the problems that we are experiencing. Of course, there are other factors as well. So reclaiming that takes so much time, so much resource. It needs so much training. It needs so much practice in the healthcare context, in clinical context. It takes a lot. And that is one of the challenges, resource constraints. Yes, so I know I said a lot. It's already 55, 52 minutes. So I want to thank you very much for your attention. And I hope this will be quite helpful. And I really encourage you to read more about Ubuntu philosophy and its application in clinical settings. And also, yes, we acknowledge, I mean, there are other challenges as well, but then what can we do? We can slowly work, but then the end solution is that we have to get back and reclaim our dignity so that we can start from where colonialism and neocolonialism has sort of damaged us, and then we can continue from there. That's very important. Thank you so much. This is the end. Well, if you have questions and comments or concerns, disagreements, anything, I'm very happy to hear. And I give the floor back to Dr. Abel or Mr. Tadeo.
So thank you very much, Dr. KIRUBEL. So that was a very engaging and thought-provoking presentation. So the concept of Ubuntu is a bit foreign to everyone here, including myself. So you've managed to present it in a digestible and easily understandable manner. So thank you very much for that. So with that said, we'll directly proceed to the Q&A session. Dr. Mahalit, you can proceed.
Okay, thank you, Tadi, and thank you, Dr. KIRUBEL, for your interesting presentation. So far, we have 2 questions forwarded. The first one is morality versus ethics.
Okay, that's nice. Thank you so much. I was looking at the chat, the comments in the chat. Very nice. Thank you so much for your appreciation. First, I want to highlight that, and I appreciate all your comments and appreciation of my presentation. I'm really thankful for that. But then, yes. So this is a very, I would say, tricky, difficult question. Of course, morality and ethics are usually confused by many. But then to start with. Giving you the difference, I want to say one sentence and then allow you to kind of reflect on that. Something that is ethically valid or ethically right can be morally wrong. And the vice versa is true. Something that is morally right can be ethically wrong in some contexts. So by that, what I'm trying to say is when we talk about ethics, we talk more about formalities, about principles. For example, there are ethical guidelines, not moral guidelines. Have you ever heard of moral guidelines? I mean, I've not. And I would love to read that if there is any moral guideline. We say ethical guideline. So ethics is concerned more concerned on principles, on establishing what is right and what is wrong, and then you just follow that. But then when it comes to morality, morality is more of an individual thing. It's more, it's how you understand things. It's how it's more based on yes. I also see one comment. Some consider the Bible or Quran as moral guideline. Exactly. That is. It's more like in your culture, in your philosophy, in your principle, and then you act based on that. So sometimes you find yourself going against with ethical guidelines, and that is not uncommon. Actually, when I was interviewing health professionals, there were some who were saying, okay, but then I don't believe in that. Ethically, it might sound okay to do that. I mean, the ethical guideline says this and that, and it is ethically valid, but then I really feel like it's wrong. So it can be wrong. And you can think of examples for yourself. So that's how I understand. Briefly, you can say, yes, the difference.
Okay, thank you. And the second one is, how do you see the privacy of patients versus community engagement? and a patient treatment decision?
That's also a tricky thing, and that is one of the challenging part in implementing Ubuntu philosophy. On one hand, of course, you have the patient's privacy and confidentiality, but then you have to involve the community. Not you have to, but then under some circumstances, it is advisable or it is recommended to involve community parties. When it is very complicated, the case is quite complicated, you get advice. And then when you do that, simply what you can do is do not expose everything about the patient. You can simply do that without mentioning, personal identifying information like the name of the person, the demographic or, the biography, if that's the right word, of the person. But then you can share the medical condition, and then you discuss, you ask for ideas from the community, for example. But then community engagement is more on healthcare system level or on the hospital healthcare setting level, not on the patient level. Patient level, it's enough if you involve the family, of course. It has to be involved, and other, maybe others who feel they are concerned and then they want to have a say. And then you ask, okay, what do you want to say? And then always the patient comes first. There's no doubt. The individual is always first. What the patient thinks, what the patient wants to say, and then you take that. And then the good thing or the nice thing in our community is usually patients kind of respect their culture. They come to you together with their cultural background, with their cultural background. So it is us who usually tend to kind of tune or sort of influence how the decision should be made. And then we say, okay, this is what you want, that's it. When the family is involved, we want to reject. It's also difficult, I understand, because you need to have a strong skill, to deal with different people. They might say conflicting things, and then it requires, as I already said, it requires resources, it requires skill and training on how to talk to, because I remember there were some health professionals who were saying to me, sometimes it's more, how do I put it? Sometimes you find yourself treating the family more than treating the patient, because especially in the context of older patients, family gets involved. The children come and then say this and that, and then you have to deal with the family. The family might be angry, frustrated, sad, and so on. So you have to deal systematically or strategically with the family as well. It requires skill, but then the patient level is that, but then community engagement is more at the healthcare provision or hospital level. And then in the patient context, of course, can hide personal information.
Okay, thank you. And the next one is legal point of view affect ethics. Will legal point of view affect ethics in medicine?
Yes, I think this is more like a statement than a question. I completely agree. People with a legal background could say much more on this. There is no doubt, and it's usually difficult to differentiate or to divide ethics and sometimes ethics and law or legal stuff, and then that is understandable. But then, some decision making that have legal implications, they also might result you in going to prison. But then when it comes to ethical and even more moral issues, then your prison is your mind. So and this, you work, so your motivation is something else. Your motivation is humanity. Your motivation is yourself, because you are a human and that person is a human. So by treating that person, you are treating or you are serving humanity. So you may not have that much of legal this and that influence, but then, yeah, some parts of ethics, of course, they involve legal issues, and then they sort of intersect, and there's no question in that or doubt in that.
Okay. Should we ask the patient permission to involve the family in the community?
Definitely. Definitely. The patient, as long as the patient can comprehend, or as long as the patient, is mentally capable of making decisions, it is very important to do that. This is the tricky part. So if the patient refuses to involve the family and the community, let's forget about the community, because as I said, community involvement is more, when you develop strategies or when you want to, get some ideas from the community for your healthcare organization or health facility. So if the patient refuses to involve the family, then it depends on the case. What is the case that the patient is refusing the family's involvement on? So if it has strong implications, that is why healthcare professionals also need cultural training and awareness and so on. If it has a very strong implication to the family and even the community in general, or to the country in general, the first step should be trying to kind of take more time with the patient, right? So there is this concept we call beneficent persuasion, at least in the field of ethics or bioethics. People use that. So it is trying to convince the patient for the patient's benefit, for the patient's context, or to benefit the patient's context, including the family or the patient's environment. So try to sort of, use different means and involve others. This is where it is also important to involve others. For example, if it is based on the patient's strong religious values, that the patient does not want to involve the family, maybe involve someone, also following the proper confidentiality, all those procedures, and then make sure that the person who is going to be involved is a skilled, relevant person. So you involve someone from that patient's religious or cultural background. It can be a colleague or someone else. And then that colleague, you have to make sure that colleague is respectful, has, good sense of, or good understanding of these things. You involve, and then you try to convince the patient. So the most important thing is that the patient understands the value or the role of the family involvement and why that decision affects the family. So yes, at some point we should, do something to sort of, help the patient understand the role of the family. Otherwise, first, yes, the patient should be asked. At least I believe that.
Okay, thank you. Again, we had a moral dilemma in our practice, especially when it involved the community's cultural beliefs. Example, we had to ask the patient with chronic diarrhea if he drank holy water, and you can imagine the family's reaction. How do you relate such circumstances with Ubuntu?
Okay, we have to ask a patient if you drank. So I'm trying to understand the question. So the idea here, as I can understand, or the question here is, so the patient with a chronic diarrhea, so are you suggesting that, I just want to clarify, you're suggesting that the patient should not take holy water, right? That's my understanding, because holy water can affect or can cause, chronic diarrhea or something. I guess that's my understanding. So in this case, yes, I can imagine. The family's reaction can be very strong. And when it comes to religion, it is quite challenging. Our society, our Ethiopian society, is a very religious society, of course. And then this can be tricky. I completely understand. There are similar examples, and these are very common, I guess. And the first important thing in this context is to try to understand the patient's perspective or the patient's context, including the family. So that's why, if you remember, I said earlier, what is health and what is disease for the patient? What is loss, or, because we have different understandings of things. For the patient, if the patient is very happy, if the patient's context, family, is very proud of dying of diarrhea while preserving his or her religious practices, because there are people who want to die for their religious values, right? A religious stand. They prefer, if you tell them, okay, this makes you ill, and then they say, oh, I would love to get ill and die from my God, right? You find people who say that. I would love to die and fall sick, and it is a win thing. It's a privilege for me to suffer for my religious values or for my God. You find people saying that. There is no doubt. So first of all, try to understand from that perspective. When you approach this patient, are you judging? Are you saying, okay, this is what life means? Instead of defining what is success in life, what is winning in life is, at least at the back of your head, try to have that and ask the patient or the family. You can involve others. This is where medical ethicists or social workers and others are very important to have in hospitals, especially in very big hospitals where there are so many people from different cultural backgrounds. So involve others maybe to kind of help you understand what the patient means by life and success in life. What is well-being for the patient? If the patient stops holy water and then get treated, maybe the patient feels his life is miserable and the patient falls sick, right? But then, of course, for you, the diarrhea is no longer there. But then for the patient, there's another disease, psychological, painful, religious disease, or spiritual disease, sorry. So that is very important to understand. So what I would suggest is try to get the patient's perspective without judgment. It's very important to approach the patient with an empty mind. It's very difficult to empty your mind. It's already full of many theories and many knowledge. But then at least, as I said, reflect, okay, what is my background? What is my religious background? What is my educational background? How am I trained? Am I influenced by this and that culture? Reflect on that and then approach the patient with that understanding and get the patient's perspectives. And then after that, try to explain it's okay. Because in Ubuntu philosophy, your ideas also matter. It is a collective decision. So don't say, okay, this is what the patient wants, and I respect, although that is awesome, but then still make sure that you also respectfully, in a culturally sensitive manner, say what you want to say, right? Okay, I appreciate that, I respect that, but then I believe that, just tell the signs, you will suffer this and that, and then involve others. Let others talk to him or her. And then in the end, if the patient insists and if the family is reacting, okay, call both of them. I know this requires time and so on. So if you have the resource, the time, bring both the family and, yeah, I understand. This is really tough. Someone is saying, I completely understand. This is why implementing Ubuntu philosophy is quite challenging. So involve, in some contexts, involve both the family and the patient, and let's discuss, okay, what do you think? Or you can also, help the patient understand that it is possible to combine things, to combine religion and the modern, let's say, medicine. And then how can we combine both of them? Maybe stop for some time and then do the holy water and so on. So sorry, I took quite some time on this. I really understand it is quite tricky, but then this is how I would approach this issue.
Thank you. And this is the last question for the session we have, I guess. So how do you balance a physician's moral principle with the ethical or legal quadrisms in context with collectivism, for instance, in abortion?
Okay, that's yeah. Someone's also saying, is that really practical? Well, I acknowledge that it is quite challenging, but then it should be part of it should be practical. At least we can have some. Anyway, let's focus on this question. So balancing the physician's moral principles with ethical or legal sort of guidelines or practices. So, I mean, the most important thing here is who comes first in clinical practice. I mean, in clinical practice, the idea is to serve patients in a way that does not hurt the physician as well. So both the physicians and the health, the patient's well-being are important. So it's not at the cost of the health or the physician, the healthcare provider. So, but then at the end, the ultimate goal, or the primary goal, is providing quality care to the patient. So in this case, we have to know that the patient comes first, or benefiting patient comes first. So in contexts where this is a very typical dilemma, I guess, in contexts where you as a physician, your values, moral, it could also be religious values, conflict with the clinical practice, one thing you have to do is to sit down and then reflect again. Does it really conflict? Because sometimes we might have a shallow or a superficial understanding of conflict or of things. So reflect on your moral values. Okay, is it something that I can compromise sometimes or not? Reflect on that. And then after you do that, if you're, okay, let's say you agree, you reach to the conclusion that, okay, this is a very serious matter to you, and then you can never compromise. In that case, what you can do is also consult or look at the legal guidelines. Okay, what does the hospital regulation say about these things? Okay, if I refuse this, if I refuse to involve in this, will I be punished? So try to understand the risks, the benefits, and the consequences, all those sort of things. After you do a thorough analysis of your context in your head, of course, and then you do some research, and then after you do that, then if it is not against, I mean, it's really up to you. I mean, sometimes we just we stand for our moral values regardless of the consequences. I mean, there are some points in my life as well. There are things, religious values or moral values, that are very dear to me. And then I chose to, okay, I'm not going to do this. So that's it. I just took and I was happy about the consequences. And I was so proud that because this is a very valuable thing for me. So you can reach that conclusion, but then check how serious the consequence that could be. And then in some cases, try to discuss, I mean, also health administrators or medical directors, be open to, the moral values or, of health professionals, and be accommodative. What can be done is that you involve others. You can ask others, and then others can make decisions. For example, in the case of abortion, you said, okay, you disagree with the idea of abortion, and this is something alien to you, or you don't want it. So other health professionals who are fine with that can do it. So try to kind of, involve others and discuss. Always dialogue and communication and comprehension can solve these things. But then in the end, if this has to be done by you and it's really against your moral values, your values also matter. So you should have the final decision on that. And then, unfortunately, be ready for the consequences. And it's really nice if the health organization or the institution also respects your decisions and try to help you, because we need to help each other, because we are there for each other.
Okay, thank you, Dr. KIRUBEL. One last question. what should we advise for a patient, his family who adamantly insist on foregoing medical treatment in favor of religious or cultural healing?
This, for me, this is somehow, I mean, this is a very common thing. Also, in my research with older patients, there were some, health professionals and older patients were saying, or all the patients were saying, okay, I don't want to be treated. I want to quit this treatment for different reasons. Some of them because they didn't like the treatment, or they tried it and they found it disrespectful. That is usually the case in older patients, because they say, okay, this generation is no longer respecting us, and I don't feel like treated, and so on. So they say that, some of them. But then some of them, they say, okay, it's not about the treatment that I have received. It's not a bad experience. It's simply because I don't like it. It's against my intent. So this is not uncommon. In this case, this is somehow similar to the previous question about the holy water and diarrhea situation. It is very important that the patient's context is respected. Again, so as I said, I mean, of course, your opinions also value. So you have to communicate your opinion. Don't as I say, don't be reserved, or don't hesitate from doing that. So communicate, try to explain to the patient and involve others. If you really think that the patient really needs this, because in some contexts, some patients are, they prefer to die, the disease is deadly, and then that, the science tells you that, and then they just want to do that, and then you get scared. So try to involve others. For example, I don't know if it is an Orthodox Christian, the patient, and then you are a Protestant Christian, maybe invite another very strong Orthodox Christian believer, also a health professional, right? So yeah, do that, and then maybe that person can influence the patient a little bit. I'm not saying that pushing the patient too much is the right thing to do, but then at least provide information so that the patient reaches an informed decision. So the patient should be well informed. So do that. Otherwise, if the patient continuously, I mean, this should be done with too much care. You should do a lot if time and resource allows you to do that. But then in the end, if the patient insists, then you have to allow the patient to go and do that treatment, or to go to the religious or cultural or traditional healing. And then that will be, and we also see that many patients and many people also, of course, get healed through religious or even traditional medical or healing practices, and that works certainly. So yes, you just allow the patient to decide that.
Thank you very much for answering all our questions, Dr. KIRUBEL, and for your amazing presentation. So we'll proceed to the quiz questions with Dr. Talil.
Thank you, Dr. Malit. Thank you, everyone. You've asked very interesting questions, and I hope they've been addressed appropriately. So our last session is going to be we're going to be attempting the post-CME quiz together. So I will share my screen over here. So these were the questions. So the first question reads, what is the central principle of Ubuntu philosophy? A reads individualism, B collectivism, C materialism, and D reads capitalism.
Okay, so it is collectivism, definitely.
Okay, thank you. The second question reads, how did colonialism influence the development of ethical frameworks in healthcare? So A reads, colonial powers imposed their own cultural values and norms onto indigenous populations, so shaping healthcare practices to align with their ideologies. So B reads, colonialism led to the preservation and promotion of indigenous cultural practices with healthcare systems, fostering diversity and inclusivity. C reads, colonial powers refrained from interfering with local healthcare practices, allowing indigenous populations to maintain their traditional ethical principles. And D reads, colonialism had no significant impact on the ethical frameworks of healthcare. as ethical standards were already established in indigenous cultures prior to colonization?
Okay, it is A. It's the first one.
Thank you. The third question reads, which of the following best exemplifies the concept of Ubuntu in clinical practice? A reads, prioritizing individual autonomy and decision-making in healthcare, even if it conflicts with cultural norms and community values. B reads, adopting a paternalistic approach to healthcare, where healthcare providers make decisions on behalf of patients without their input. So C reads, embracing a collaborative and inclusive approach to healthcare, where patients, families, and communities are actively involved in the decision-making and care. And D reads, following strict adherence to medical protocols and guidelines, regardless of the patient's cultural background or preferences.
Yeah, it should be C. Yes.
Thank you. So the last question is a case-based question. So it reads, in a rural community in Ethiopia, an older patient, Abebe, is admitted to the local clinic with symptoms of a serious infection. Abebe's family members, following the principle of Ubuntu, insist on being actively involved in his care, emphasizing the importance of collective decision-making and community support. So the question reads, how should healthcare providers in this scenario respond, considering the principles of Ubuntu philosophy? A reads, respect the family's wishes and involve them in the decision-making process, recognizing the importance of community support in Abebe's care. B reads, make medical decisions based solely on the principle of individual autonomy. C reads, disregard the family's concern and proceed with the treatment without their involvement, as it may impede medical progress. And D reads, offer Abebe the option to choose between Western medical treatment and traditional healing practices, allowing him to decide independently.
Should be A.
Okay, thank you. So we're done with our webinar. So thank you very much, Dr. KIRUBEL, for delivering this very interesting and engaging webinar. I hope it has sparked a meaningful conversation and it has challenged us to reevaluate the current healthcare landscape in our country. So thank you, Dr. Abel from ISIM, for joining us. Thank you to everyone that has attended to the very end. So we'll have another CME coming up in a few weeks' time. So join our social media outlets to be informed of our upcoming activities. So once again, thank you and good night.
Thank you so much. Thank you so much for having me. I really appreciate it. And for your engagement, everyone.
Thank you.
Bye.